That's what we are going to hear. Welcome everybody. I would like to congratulate you on your medical festival. I will try to elaborate on antidepressants and their link to sexual functions. My lecture will take between 15 to 20 minutes. First of all, I will be talking about sexual function and its relationship with antidepressants and the sexual dysfunctions that are induced by antidepressants will be another part of my topic. And finally, how we can manage the sexual dysfunctions. When I was preparing for my presentation today, when I studied the topic, the main question in my mind was, in order to answer this question, and I also gave it to one of my residents as a thesis topic. As you can see, antidepressants have many side effects. Within the first 2 weeks, they are more frequent, and over the time, a tolerance develops and they improve. The side effects also include sexual dysfunction. This is not the case for them. In the initial phase, they are more prevalent and then they improve. However, some part of them are sustained for a longer period of time. We should consider the underlying causes, whether there is a genetic problem or a hormonal problem in this group where there is sustained sexual dysfunction. And what are the differences to the other group with the transient side effect profile? This was the main question that I was trying to answer. However, unfortunately, I couldn't find the answer to this question in the literature. Right now, I consider myself fortunate because we have some important lecturers and professors among us. Maybe at the end of my lecture, they will be able to enlighten us. By the way, when I studied the topic, there is an important reference who I cited in my presentation, Nevzat and Tayfun, professors. The two professors have an important review on these issues. If I looked at the 2009 guidelines, they are quite similar, and their review was published in 2001. It was really very beneficial. For more detailed information, you should read this review article. When you talk about sexual dysfunction, you first of all need to consider the possible causes, which are numerous. We have medical conditions, we have psychological and psychiatric factors, and there are many medications that induce sexual dysfunction, starting from antihypertensives, going on with sedatives, anticonvulsants, neuroleptics, and of course antidepressants. What is the relationship between major depression and sexual dysfunction? First of all, depression per se leads to sexual dysfunction. And if you look at the symptoms of depressions, they are really actually symptoms of depression per se. And the antidepressants that are used to treat the depression may either induce the sexual dysfunction or make the situation more grave. And these kind of side effects lead to discontinuation of the treatment by the patient. In short, patient non-compliance. Sexual dysfunctions make the management of major depression even more difficult than it is. Before the use of medications, we see a high number of sexual dysfunction related with depression. There is a study conducted by Kennedy et al. 134 patients with major depression were observed, and in the last 1 month period before the treatment of antidepressive therapy, sexual functions were reviewed, and it was shown that 49% of females and 26% of males had no sexual activity at all in the last month. Reduced libido is seen in 50% of women, and arousal problems is also observed in 50%. The same problems are observed in 42% and 46% of the men, respectively. Delayed ejaculation is observed in 22% of men. This is even before the antidepressant therapy is started. And these investigators have published a study on 401 patients on SSRI. They make a phone call review and they try to identify the side effects that are related with SSRI. And sexual dysfunctions are of course included. And within the first 2 weeks after the start of the treatment, the side effects are seen in 70% of the patient, which goes back to which increases to a further 83% after 3 months. Sexual dysfunctions, let us look at them one by one with their modes of actions, how they happen, how they occur. Libido is related to the dopaminergic activity in the mesolimbic pathway. And with this pathway, a sexual arousal happens. Inhibition of the serotonin reuptake leads to stimulation of the serotonin receptors with a diminished activity, dopaminergic activity in mesolimbic system. The libido is decreased. Activation of 5-HT receptors reduces the secretion of noradrenaline from the hippocampus, which in turn is important in creation and maintenance of libido. SSRI increase the secretion of prolactin from the hypothalamus, which leads to a decrease in sexual desire and performance. Medications such as nefazodone and mirtazapine are 5-HT2 receptor antagonists. They don't have a negative effect on libido. Bupropion inhibits the dopamine reuptake and increases the secretion of mesolimbic dopaminergic, which may have a positive effect on libido. A similar mechanism is seen with regard to arousal. Here again, the inhibition of serotonin reuptake leads to a decrease in the dopaminergic activity in the mesolimbic system, which in turn decreases the sexual arousal. Peripheral symptomatic and parasympathetic activity is related to the erection and clitoral swelling reflexes. The priapism observed in trazodone treatment is induced by the blocking effect of 5-HT2 and alpha-2 receptors. Nitric oxide leads to vasodilation, and it is also associated with penile erection and clitoral arousal. Nitric oxide is eliminated using phosphodiesterase. SSRI and tricyclic antidepressant strongly inhibit the nitric oxide synthase enzyme, which may interfere with arousal. Acetylcholine and noradrenaline in balance help sexual arousal. The alpha-1 adrenergic activity in man regulates the venous return in corpus cavernosum, and peripheral cholinergic surge leads to a filling of the corpus cavernosum and helps erection. Anticholinergic side effects lead to difficulties in sexual arousal. Cholinergic agonists such as neostigmine and botanical have positive effects on erection problems and may be used in some instances problems induced by SSRIs. In terms of orgasm and ejaculation, sympathetic and parasympathetic components of the autonomous nerve system are the modulatory mechanism. The partially central nerve system may have an effect. Inhibitory serotonergic fibers and stimulatory noradrenergic fibers are the controlling effects. SSRI using 5-HT2 mediated noradrenergic inhibition method may lead to a delayed orgasm or anorgasmia. Peripheric nociceptive stimulation, which is partially modulated by serotonin, may also lead to the same condition. The motor innervation of the human vas deferens is basically noradrenergic. TAD and SSRI strongly inhibit the mechanical contractions of the vas deferens. The strong modulatory inhibitory effect on the vas deferens motility may be responsible for their effects. And painful ejaculation seen with tricyclic antidepressants are usually suggested to be responsible on their effect on sperm transport and the associated smooth muscles. To summarize all the issues, for desire and libido, we have an increased dopamine, testosterone, and estrogen levels, and prolactin levels are reduced. For arousal, acetylcholine, dopamine, and nitric oxide levels are increased, and for orgasm, norepinephrine is increased, and serotonin is decreased. In SSRI-induced sexual dysfunctions, the blockage of serotonin reuptake decreases the dopamine activity. SSRIs may increase prolactin, and SSRI may affect on spinal reflex mechanism to impair ejaculation on the organism. And the clinical manifestations. Sertraline has a much more pronounced effect on sexual functions and the disorders compared to other SSRI medications. In other studies, again, paroxetine has been found to cause more sexual side effects compared to other SSRI. In studies performed on SSRI, sertraline and paroxetine have been shown to cause more sexual side effects. In France, Elixir trial was conducted. Here, citalopram, fluoxetine, fluoxamine, and paroxetine and sertraline were compared, and in 74.2% of the patient, sexual dysfunction was identified among the patient population. The most frequent side effects were decreased libido or absence of libido, followed by orgasm and erectile dysfunctions. In the previous studies, sexual dysfunction has been reported not to cause important sexual dysfunction. And sexual dysfunction was seen more frequently among men compared to women. However, recent studies show that when venlafaxine and milnacipran have a similar prevalence of sexual dysfunction as much as SSRIs or tricyclic antidepressants. Brennan and co-workers have conducted the study in 2003 using duloxetine, placebo, and paroxetine were compared to duloxetine. Duloxetine causes more sexual dysfunction compared to placebo, but less side effects compared to paroxetine. Clayton and co-workers have conducted a trial using reboxetine, and they again compared it to placebo, and it was shown that there is no significant difference in terms of incidence of sexual dysfunction compared to placebo. Another study comes from Versiani and co-workers, and sexual dysfunction induced by reboxetine is reported in 10% of the patient population. We have a study from Turkey by Murat Atmaca. He was my chief resident, and then he was also my professor. And this group again compared tianeptine with other controls. It causes the same incidence of sexual dysfunction, and the incidence is less than SSRIs and tricyclic antidepressant. In this study conducted by Atmaca and co-workers, in patients with a present sexual dysfunction, tianeptine is given back, and it was shown that sexual dysfunction was reduced after the administration of tianeptine. Mitrazepine blocks the noradrenergic alpha-2 autoreceptors, and it is responsible for the secretion of both noradrenaline as well as serotonin. It blocks the serotonergic 5-HT2 and 5-HT3 receptors. On the other hand, it has a slight affinity to 5-HT1A receptors, and therefore mitrazepine causes a low incidence of sexual dysfunction, and the intensity is less still. Trazodone is a selective, however weak, serotonin reuptake inhibitor. It blocks 5-HT1, 5-HT2, and alpha-2 adrenergic receptors, and it is supposed to be responsible for priapism. And the incidence is reported between 1 in 1,000 and 1 in 10,000. Bupropion has a dopaminergic effect. And within the framework of stimulatory effects, it may be used in the management of sexual dysfunction induced by antidepressants. On this issue, in 2000, again with the team from LSU, we have conducted a study together with this team. Clomipirene, fluoxamine, sertraline, paroxetine, moclopimid. Using my patients were compared in terms of decreased libido, erectile dysfunctions, and orgasm problems, and you can see the incidences on this chart. Clomipirene, paroxetine and moclopimid are more innocent compared to the other test drugs, study drugs. Another study was conducted by Ulu Ojak and his co-workers on 49 male patients. Paroxetine and paroxetine was used, and the observation is the most common side effect among male patients was isolated orgasm problems. And isolated ejaculation problems was observed in 61.22%. This is another study that we have conducted. These are patients with erectile dysfunction on antidepressant therapy, and sildenafil was given to these patients to treat the condition. And in patients who received sildenafil on a dose-dependent manner, the sexual functions improved in a dose-dependent manner. Well, how should we manage the sexual dysfunctions that are induced by antidepressants? The first step for a careful follow-up, you should monitor the patients in harmony for a careful follow-up. This is actually the question I have in my mind, because in patients with sexual dysfunctions using antidepressants, if you don't do anything, after some time they develop tolerance and the sexual dysfunction improves spontaneously. It's only a small proportion of our patients, but they do improve. Second step is the use of medications at the minimum effective dose. There are certain risks involved with this. If you talk about a minimally effective dose, there is the risk that the disease recurs. You should be careful about this. The third step is the drug holiday, off-drug period, with sertraline and paroxetine. Along the course of the treatment, drugs are discontinued for 2 days on the weekends, and there is a 50% reduction in libido and orgasm problems. However, for the long fluoxetine with a prolonged effect, this drug holidays are not much effective. Another approach would be drug switch from SSRIs to or tricyclic antidepressant. You may switch to bupropion, mirtazapine, and tianeptine. However, there are some question marks about the antidepressant effect of bupropion. So right now, it is not one of the label indications of this medication in Turkey. Or another possible switch option is from SSRIs to moclobemid or tianeptine. And finally, pharmacological antidotes may be used. And Professor Nevzat, this is a chart that I have taken from their article review in 2004. Here we have the alternatives for antidotes that may be used to treat this condition. And on this slide, this is a guideline published in 2009. We see the pathway. First of all, we need to exclude organic or psychogenic causes, and secondly, this is the watchful waiting. Third step, to decrease the dose of the offending drug to the lowest, to the minimal effective dose. The fourth step is switch to a different drug. Step 5 is adjunctive therapy, and step 6 is refer the patient to specialized centers. Thank you very much for your patience.